Okay, now we're continuing on with mood disorders. In ATI, I left off in chapter 12 with depressive disorders on page 98. And notice on page 99 you can get an opportunity to see a video, Understanding Major Depression. I think I will just go ahead and show you in class the films. Then notice on page 101 they review the medications for depression, the SSRIs, the selective serotonin. Remember that was going to be a key word with depression. Reuptake inhibitors. There's Celexa, Prozac, and Zoloft in the brand names. The tricyclic antidepressants like amitriptyline that I happen to take for back pain. The monoamine oxidase inhibitors, or MAOIs. Nardil is the brand name of one. And what are those used for? And what substance do they contain? Tyramine, remember that? And so they don't eat certain foods. And let's see if they list them here. Yeah, what ATI lists is ripe avocados or figs, fermented or smoked meats, liver, dried or cured fish, most cheeses, some beer and wine, and protein. Dietary supplements, so I didn't know that. That's a new one to me. And then atypical antidepressants, Wellbutrin, that's usually used for anti-smoking, but it is antidepressant. And then the SNRIs, Venlafaxine, I'm thinking that might be Effexor, and Duloxetine Cymbalta. I haven't looked that up, so be sure and check that one. And then I don't know if these application exercises are exactly like they were, but it would be good practice to go over those again. Then we go on to chapter 13 with the continuation of psychobiologic disorders and the bipolar disorders. On page 107, the overview, bipolar disorders are mood disorders with recurrent episodes of depression and mania. The bipolar disorders usually emerge in late adolescence or early adulthood, but can be diagnosed in the school-age child. And so they go into a discussion here about how difficult it is to distinguish from ADHD and some other mostly children's disorder. But you do see on the adolescent unit, I believe, some diagnosing of bipolar. I don't know that I've seen that in the pre-ad unit at Royal Oaks. Then the third bullet discusses periods of normal functioning alternating with periods of illness, though some clients are not able to maintain full occupational and social functioning. So I have heard of disability payments due to bipolar disorder and these kinds of disorders. I would think if they were good with taking the medication that they could go on and function with a job. Psychotic, paranoid, and or bizarre behavior can be seen during the episodes of mania. A little bit hard to distinguish sometimes, I guess, between a manic episode and a psychotic episode. Care of a client who has bipolar disorder mirrors the phase of the disorder the client is experiencing. Now you have a chart for acute mania, continuation or remission of clinical manifestations, and maintenance or increased ability to function. Then our last bullet on this page is behaviors shown with bipolar disorder, including mania, hypomania, mixed episode, or rapid cycling. And again, it's very important to remember that 4 or more episodes of acute mania within a year would equal rapid cycling. So we expect they normally would go through 3 episodes, and it's certainly not a daily thing where they would be manic one day and depressive another. It's a matter of weeks and months. On page 108, they talk about bipolar disorders, and they delineate the bipolar 1 and bipolar 2 and the cyclothymia. Bipolar 1, the client has at least 1 episode of mania alternating with major depression. In bipolar 2, the client has 1 or more hypomanic episodes alternating with major depressive episodes. And cyclothymia is the client having at least 2 years of repeated hypomanic manifestations that do not meet the criteria for hypomanic episodes alternating with minor depressive episodes. Comorbidities associated with bipolar disorder are, of course, substance use disorder, and this client who has substance use disorder tends to experience more rapid cycling or mania than clients who do not. When I was at the Adult Pathways substance abuse unit for my graduate work through MU. I had that as a clinical site, but I had to have clients, not just clients with substance abuse, but clients with what they called a dual diagnosis, and your text here calls those comorbidities, but I had to deal with clients that had substance abuse and bipolar disorder, or substance abuse and depression, or psychosis, or some mental health problem other than just the substance abuse. Substance use is often a means of self-medication. It can have a direct impact on the onset of the mental health disorder, especially if a client is predisposed. So it's been an interesting discussion to me from the time I studied my brother's problems to when I went into it in graduate work. I would ask the psychologist, which do you think comes first? Do they have this substance abuse disorder and then they get these brain disorders actually and become diagnosed with bipolar disorder? Or do they feel so badly sometimes that they self-medicate with these street drugs and get into substance abuse first? And he said, it's not really important. The first one I talked to about that said, we don't discuss that too much because we just have to deal with what we're given. And they have bipolar disorder many times with substance abuse as another problem, and they have to treat all those. And the new 2014 also has a video, Understanding Bipolar Disorder, and I plan to show you in class the films that I already have. Be sure and look at the charts they have on page 109, and then patient-centered care on 110. The medications, what medication would we expect with bipolar disorder? Lithium, that very interesting one, lithium. And they also use anticonvulsants, I think mainly Depakote. They can use benzodiazepines such as Ativan, and we've learned recently that there's a young student in Mrs. Mitchell's class whose seizures are controlled with oral lorazepam. Antidepressants such as SSRIs, fluoxetine, or Prozac are used to manage a major depressive episode. And hopefully it doesn't go into, in this section, the therapeutic limits on lithium and the fact that you need to watch fluid and sodium levels with these patients, but that's probably covered in a different section. They do discuss electroconvulsive therapy, and the nurse can have quite a job, and they outline that client education on that. And complications are physical exhaustion and possible death. So it is risky. It's one of those, you would have to make sure they'd signed a consent for this treatment and understand it fully. A client in a true manic state usually will not stop moving and does not eat, drink, or sleep. This can become a medical emergency, and the nursing actions to prevent client self-harm, decrease the client's physical activity, ensure adequate fluid and food intake, promote an adequate amount of sleep each night, assist the client with self-care, and manage their medications for them. It goes on to application exercises now, and then that finishes bipolar disorder. I will continue in a few minutes with the essential questions.